This is Chapter 20, Antimicrobial Drugs. So what you're seeing here is Pseudomonas aeruginosa, and it actually has an intrinsically advanced antimicrobial resistance mechanism, and it's often associated with serious illnesses. So what we're going to be talking about today is antimicrobials that we use to control all of these microbes that we come in contact with. So here we're going to discuss the history of chemotherapy. So the history of chemotherapy started with selective toxicity. It's selectively finding and destroying pathogens without damaging the host. And so chemotherapy is the use of chemicals to treat a disease. And an antibiotic is a substance produced by a microbe that in small amounts inhibits some other microbe. And antimicrobial drugs are synthetic substances that interfere with the growth of microbes. So kind of going back to the history, Alexander Fleming discovered penicillin and it was produced by the bacterium Penicillium in 1928. And in 1932, protonsyl red dye was used for streptococcal infections. In 1940, we had the first clinical trials of penicillin, and today there's a growing problem of antibiotic resistance. So one of the first observations of antibiosis is where you kind of see this zone of clearing around these antibiotics, and you can see several other ones. There's one here, there's one here, there's one here, there's one here, and you can see that these are kind of these clearing zones are very important for them to actually be able to survive, and evolutionarily it helps them to kind of crowd out some of the other ones. So this is a representative source of antibiotics. So for gram-positive rods, we've got these different antibiotics that come from different places. And so we see a lot of these ones that are actually produced by bacteria, which is pretty interesting. Some interesting ones that I'll point out to you, neomycin. If you guys have ever used Neosporin on a cut or a scrape or something like that, that's where they've got it from. Streptomycin is going to help us kill some streptobacterias and stuff like that. And then erythromycin is a very, very often prescribed antibiotic. So some other representative sources for fungi, cephalosporin is going to go to cephalothin. Penicillin is going to be made by Penicillium. So you guys have seen those before. So here's your check your understanding questions. Make sure you guys take a moment to take a look at these. All right, here's your learning objectives for the next section. And so let's talk about the spectrum of antimicrobial activity. A narrow spectrum of microbial activity are drugs that affect only a narrow range of microbial types. A broad spectrum antibiotic affects a broad range of gram-positive or gram-negative bacteria. And a superinfection is an overgrowth of normal microbiota that is resistant to antibiotics. So this table right here kind of shows you the spectrums of some of the antibiotics we have. I'm going to start with the bottom. Tetracycline is a very useful one, and it kills a lot of different bacteria, specifically prokaryotes, but it's going to kill gram-positive, it's going to kill gram-negative, as well as chlamydias, rickettsias, and mycobacterium. Streptomycin will mainly, work on gram-negative bacteria and microbacteria. Isoniazid is going to kill the mycobacterium, and penicillium is going to focus on the gram-positive bacteria. For some of our other eukaryotic ones, we have some different things going on here. Acyclovir is one of our only very useful antiviral medications. For fungi, we have some different ones, and depending on where the fungi is growing, it's going to be treated different ways. So here's your check your understanding questions. Make sure you guys take a moment to take a look at these. So we're going to identify 5 modes of action of microbial drugs, and I want you to know these 5 modes. That's important. So the action of microbial drugs, you either have bactericidal, where it's going to kill the microbes directly, or bacteriostatic, where it's going to prevent the microbes from continuing to grow. And so we'll go through these really quick, and then we'll go through each one of them in a little bit more detail. So the first one is inhibition of cell wall synthesis. The second one is inhibition of protein synthesis. The third one is inhibition of nucleic acid replication and transcription. Number 4 is injury to plasma membranes. And number 5 is the inhibition of essential metabolite synthesis. And so we'll go through each of these, like I said. So inhibiting cell wall synthesis, the penicillins prevent the synthesis of peptidoglycan, and this is going to cause bacteria not to be able to grow and develop and bud off of each other. So you can see here how before penicillin they look all pretty, but after penicillin they have big old holes in them. The next one is inhibiting protein synthesis. And so this is where they target the bacterial 70S ribosome, which is great because it's different from the 80S ribosomes we find in our bodies. And so ones that you might see here, chlorophenol, erythromycin, streptomycin, and tetracyclines. The next one is the inhibition of protein synthesis. And so if you shut down protein synthesis, well, the cell's not going to be able to live very much longer. The next one is injuring the plasma membrane, where the polypeptide antibiotics can change the membrane permeability, and antifungal drugs combine with membrane sterols to kind of disrupt the membrane. So here you can see a yeast getting damaged by an antifungal drug. Inhibiting nucleic acid synthesis is going to interfere with both DNA synthesis and transcription. And inhibiting the synthesis of essential metabolites is where you're going to get antimetabolites compete with these normal substrates for an enzyme. So sulfonamides are going to compete with para-aminobenzoic acid, or PABA, stopping the synthesis of folic acid. So here's your check your understanding questions. Make sure you guys can talk about the 5 different methods that we talked about at the very beginning of this. So here's your learning outcomes for the next section, and more of your learning outcomes for this next section. And one more slide of them. Here we go. All right, so this table has a bunch of antibacterial drugs. I'm not going to expect you to memorize these. I think that's a little much to be memorizing. But what we need to take a look at is all of these ones do different things. And so when a doctor decides to prescribe a specific antibiotic, a lot of times if they don't know what it is, they'll prescribe a very broad spectrum antibiotic. And that's good, except for it, kills a lot of the other good bacteria that we have around. And so here we can see a lot of broad spectrum antibiotics, and so they're listed by methods of action here. And so you can see how, they all have little notes on them and stuff like that. And so some of these are only used to treat MRSA infections and some other very, resistant infections. So the strength of these is also taken into effect. So differential groupings of cephalosporins. We have first, second, third, and fourth generations. Cephalosporins were some of the first, drugs that would help us to do some type of organ transplant, and so they have different levels of kind of action, and so as you go up, it gets more intense and more strong of a cephalosporin there. So I'm not going to read all these to you, but there are a few interesting ones. These are antifungal, antiviral, and antiprotozoan and antihelminthic drugs. We don't see a lot of antiprotozoan and antihelminthic drugs here in America. Most of the water that we get is very clean compared to a lot of the world. And so as we go through here, so antifungal, these affect the cell walls. You can see several different ones of these. Antiviral drugs, and so a lot of these are going to help to treat different viruses. One that I will point out to you, osmeltivir, is the regulated name for the Tamiflu, and this is one of the more important antiviral medications that we have right now, because if you've ever gotten the flu and you got Tamiflu with it, you'll feel better in about 3 days. If you don't get Tamiflu, you'll be feeling better in about 10 days. So it's definitely one of those things that if you do feel like you have the flu, go ahead and go to the doctor and see. There's some other ones that are there. AZT is primarily used to treat HIV here. Acyclovir, this is going to be one of the ones that we use against herpes viruses, and you don't necessarily want that, so be careful. And then we've got a few other ones that treat some other things. this one right here, this one that says possibly effective against smallpox, well, they've never tested it because guess what? We vaccinated and got rid of smallpox. Thank the Lord. So this next one, so these are going to help to do some different things. There's a couple of different ones. Most of the time when you're treating HIV, you're going to be on a cocktail of medications. You're not just going to be on one specific medication that's going to do everything. You're going to be on several different ones that are going to help to control the spread of that virus. Let's see. The chloroquine, this is going to be effective against malaria. And then there's a couple of other ones on these slides that I wanted to mention to you guys. So tapeworms, they're going to go give you niclosamide. Let's see, what's the other ones that are cool? Scabies in life, ivermectin. I actually had a girlfriend one time who got scabies, and she had to rub this stuff all over her for about a week and a half. Well, it worked, but she also had scabies somehow, and I don't know where she got it from. So antibiotics, inhibitors of cell wall synthesis, the penicillins are generally going to be this particular one. They're going to contain this beta-lactam ring, and they'll talk about this beta-lactam ring a little bit more. The natural penicillins are going to be extracted from penicillium cultures. They have a very narrow spectrum of activity, and they're very susceptible to penicillinases, which are going to go through and break up this beta-lactam ring. And so the semi-synthetic penicillins, these are going to contain chemically added side chains, making them resistant to the penicillinases. So as I mentioned, the beta-lactam rings here are kind of shaded in a different color over here. Penicillin G is going to require injection, but penicillin V can be taken orally. And so you can see there's some slight differences in the chemical structure. But the common nucleus is this shaded part over here. And so this is the same. Semi-synthetic penicillins, oxalicin and ampicillin, they're going to have a lot of different reactions there. Ampicillin is going to be an extended spectrum, but the oxacillin is going to be a narrow spectrum. So very interesting here, penicillin G versus when it's introduced via intramuscular injection versus whether it's given orally. You can see there's a lot more concentration in the blood versus if it's given orally. And so this retention of the penicillin is kind of low for both of these, which is why you have to go and you have to take it again and again. So you take it every 4 to 6 hours or something like that, and you'd get these extra bumps, and then you continue to have this thing until you kill off the bacteria that's making you sick. So what can a pilicinase do? It just breaks down the beta-lactam ring, and so it breaks the bond right here, and then you get a carboxylic acid on one end, and you get a amine group on the other. So penicillinase resistance penicillins, methicillin, and oxacillin. Extended spectrum penicillins are effective against gram-negative as well as gram-positives, so the aminopenicillins, ampicillin and amoxicillin, and penicillins plus the beta-lactamase inhibitors contain clavulanic acid, which is a non-competitive inhibitor of the penicillinase. Carbapenems, these substitute a C for an S and add a double bond to the penicillin nucleus. These are very broad spectrum. Monobactams are going to be synthetic single ring instead of the beta-lactam double ring. They have a very low toxicity and work against only certain gram-negatives. Cephalosporins, these work very similar to penicillins. The beta-lactam ring differs from penicillin. It's grouped accordingly to their generation of development. The polypeptide antibiotics, bactitracin, is topical application. It works against gram-positives. Vancomycin is a glycopeptide. It's the last line of defense against antibiotic resistance MRSA. Generally, if you go into the hospital for some type of surgery, right before surgery, they will give you some vancomycin. And this is one of those things that's only given in the hospital because they don't want to start giving it out to patients, and patients will be like, well, I want the best one. You can also get vancomycin-resistant enterococci, VRE, and that's very smelly. Okay. So here you can see a little bit different. So the cephalosporin nucleus also has that beta-lactam ring, but it's kind of integrated differently into the structure of the molecule. INH, this inhibits the mycolic acid synthesis in mycobacteria. Ethambutol, this inhibits the incorporation of mycolic acid into the cell wall. And so here's your check your understanding questions for section 4. Chloramiphenicol is going to inhibit the peptide bond formation, and it's going to bind to the 50S subunit of the 70S ribosome. It's synthesized chemically, and it's a very broad spectrum, and it can suppress bone marrow and affect blood cell formation. So here's the structure of that. And aminoglycosides, these are when amino sugars are linked by glycoside bonds. They change the shape of the 30S subunit of the 70S ribosome, and they can cause auditory damage if they're given too high of concentrations. So you can get streptomycin, neomycin, and gentamicin here, and so if you give too much, you can actually cause some type of deafness. Tetracyclines are generally produced by Streptomyces species. They interfere with the tRNA attachment to the ribosome, and they're very broad spectrum. They penetrate tissues, making them valuable against rickettsia and chlamydias, and they can suppress the normal intestinal microbiota. So they call it tetracycline because tetra means 4, because it has 4 different rings in it. 1, 2, 3, 4. But they have to be very careful giving out tetracyclines because tetracyclines can turn your teeth this dark stained color. Glycocyclines, these are broad spectrum bacteriostatic. They bind to the 30S ribosomal subunit and inhibit rapid efflux. They're administered intravenously generally, and they're very useful against MRSA. Macrolides, these are going to contain a macrocyclic lactone ring, and they're a narrow spectrum against gram-positives. So here you can see that macrocyclic lactone ring. And so this is a representative macrolide. This is erythromycin here. This is a very commonly prescribed antibacterial drug. Streptogammins, these attach to the 50S subunit and work against the gram-positives that are resistant to other antibiotics. The oxazolidinones, these are synthetic. They combat MRSA because they can bind to the 50S and the 30S subunit. And pleuromutilins, these are going to be topical and effective against gram-positives. So here's your check your understanding questions. Please make sure you take a moment to take a look at these. Lipopeptides, like daptomycin and polymyxin B, these affect the synthesis of bacterial plasma membranes. And so if you don't have a plasma membrane, you can't have an intact cell. So here's your check your understanding question. And then now we're moving on to nucleic acid inhibitors. Rifamycin, this inhibits mRNA synthesis. Quinolones and fluoroquinolones, these are going to be synthetic, and they're going to inhibit DNA gyrase. Norafloxacin and ciprofloxacin, these are very broad spectrum, relatively non-toxic. This is why a lot of times they are prescribed pretty regularly because of that non-toxicity there. Sulfonamides, these inhibit folic acid synthesis needed for nucleic acid and protein synthesis, and they completely bind to the enzyme for PABA production, a folic acid precursor. The combination of trimethoprim and sulfamexazole is an example of drug synergism. So this pathway here, which I'm not going to ask you to memorize, if you mix them together, eventually you will get an increased effect from these two. So here's your check your understanding questions for section 8. Next, we'll talk about antifungal drugs. And so these are agents that are going to affect fungal sterols, like polyenes, azoles, and allylamines. And so a lot of these are going to be things that are going to be topical because most of the time we deal with fungal infections that are on our bodies or on the outside of our bodies. If anybody's ever had athlete's foot, this is one of those. So here you can see the structure of the antifungal drug amphotericin B. It's representative of the polyenes, and you can see how kind of big this is. The structure of this other antifungal drug, miconazole, this is representative of the imidazoles here. And then some other antifungal drugs that affect the cell walls, echinidins. These are going to inhibit the synthesis of beta-glucans and agents inhibiting nucleic acids. Fluoxetazine, cytosine analog, interferes with the RNA synthesis. Antifungal drugs continued. Griselvin, it's produced by Penicillium. Tolnaftate is for athlete's foot. Pentamidine is going to be an anti-pneumocystis drug, and it's going to bind to DNA. Antiviral drugs, generally what they do is they will be entry and fusion inhibitors, or they will uncoat the genome, uncoat genome integration and nucleic acid inhibitors. And so they're going to block the receptors on the host cell and bind to the virus, is what the entry and fusion inhibitors will. And so they'll block the fusion of the virus in the cell. The second class here is going to prevent that viral uncoating, inhibit the viral DNA integration into the host genome, and the nucleoside analogs inhibit RNA or DNA synthesis. So here you can see how the cyclovir structure resembles the nucleoside deoxyguanosine, and so it kind of interferes with that and causes it to not be able to continue any type of transcription or translation or any DNA copying. So the structure and function of a cyclovir, and so this is one, so a cyclovir is going to resemble that nucleoside, and so when it goes through here, it's going to not be able to continue on through this, and it's this false nucleotide is going to kind of stop the whole entire process. Antiviral drugs, so interference with assembly and the release of viral particles. Protease inhibitors do this. Exit inhibitors inhibit the neuraminidase, which is an enzyme required for some viruses to bud from the host cell. Interferons are produced by viral infected cells to inhibit further spread of the infection. One that we produce as humans, imiquimoma, whatever this one is, promotes the interferon production inside the body. Antiretrovirals, so these are going to treat HIV and AIDS. So there's this whole drug cocktail that's given here, and I'm not going to tell you, I'm not going to read these to you because most of them are very difficult to pronounce. But what we see here is we see that, these people are going to be taking a lot of different drugs to kind of stop the virus from spreading and stop it from being able to do what it needs to do to live. Antiprotozoan and antihelminthic drugs, quinine and chloroquine, these treat malaria. Artemisinin kills Plasmodium that causes malaria. Metronidazole or Flagyl interferes with anaerobic bacteria as well as Trichomonas, giardiasis, and amoebic dysentery. Antihelminthic drugs, niclosamide, this is going to treat tapeworms. Praziquantel is going to treat tapeworms and flukes. Mebendazole and albendazole is going to interfere with nutrient absorption and treats intestinal helminths. And ivermectin is going to treat roundworms and mites. So tests to guide chemotherapy. We've gone over this whole stack of drugs that we can give somebody if they're sick. But how do we know which one to use? And so this is what's going to tell us here. Okay, so the disc diffusion method, or the Kirby-Bauer test, when I learned this, it was still Kirby-Bauer, and the test for the effectiveness of chemotherapeutic agents. And so what happens is I'll just tell you guys, you drop these paper discs onto a petri dish after you've kind of flooded it with a bacterial culture. And so what you should have done, and this doesn't happen that often, you culture it from the patient, and you take it and you grow this culture up, and then you flood it onto a plate, and then you drop these discs on there. And so these discs are dropped by a little kind of mechanism where you pull it, and it drops them all kind of equally spaced from each other. So if you see here, these are kind of going around the circle here, and then there's 3 in the middle. And so these are kind of far away from each other. And so you can see this one seems to be working pretty well. You can see the ones that are working because they have these big zones of clearing around them. The ones that aren't working are the ones that don't really have a big zone of clearing. Now, these might work, but they might not be working in a high enough capacity. And then this one has some type of color change going on, and we don't know what that is, but hey, we've got enough choices here to where we know that something will work. The E-test, this determines the minimal inhibitory concentration, and it's going to be the lowest antibiotic concentration that's going to prevent that bacterial growth. And so here you have that E-test, and so it's got a gradient diffusion method that determines the antibiotic sensitivity and estimates the minimal inhibitory concentration. And so what happens here is we've got this zone, and so what it's doing is it's going up in concentration on this strip. And so the further out, or the further in you get, the higher the concentration is. Broth dilution test. This determines the MIC, the minimal bactericidal concentration of an antimicrobial drug, and it tests the organism. The test organism is placed into the walls of a tray containing dilutions of a drug, and the growth is determined. Antibiograms reports that are recorded the susceptibility of organisms that are encountered clinically. So here you can see these different kind of things here. So we're looking at different concentration, and here's the lowest going to the highest over here. And so you can see the lowest concentrations, and a lot of them are growing. So streptomycin, this bacterium is very sensitive at all concentrations to it, but you can see some of these other ones, it's kind of sensitive all the way up here, and you can kind of see a little bit right there. So you kind of got to just read these and look for them. But if I was a provider, a healthcare provider, I would say, well, streptomycin is my choice here because at even a low concentration, it's going to inhibit the growth of that bacteria. So here's your check your understanding question. If you got any questions, please make sure you ask them. So next, we're going to describe the mechanism of drug resistance. So persister cells are microbes with genetic characteristics allowing for their survival when exposed to an antibiotic. And superbugs are bacteria that are resistant to large numbers of antibiotics. Resistance genes are often spread horizontally among bacteria on plasmids or transposons via conjugation or transduction. So other mechanisms of resistance, we can have enzymatic destruction or inactivation of the drug, prevention of penetration of the target site within the microbe, alteration of the drug's target site, a rapid efflux or ejection of the antibiotic, and the variations of mechanisms of resistance. So here, we've got a couple of different ones here. These resistance, they're either going to block the entry, they're going to inactivate enzymes, they're going to change the target molecule, or they're going to be able to just get rid of the antibiotic. So here is the development of an antibiotic-resistant mutant during antibiotic therapy. What happens is we start with the antibiotic resistance here, and it starts down here at 0. And this is the number of bacteria that are going to be, doing it. So we start the antibiotic therapy here, and oh, hey, the number of bacteria goes down. How wonderful. And then they start to become resistant, and they come back. And so the ones that come back are going to be resistant to the antibiotic that has already been given. The misuse of antibiotics is selected for resistance mutants. So using outdated or weakened antibiotics, using antibiotics for the common cold and other inappropriate conditions, using antibiotics in animal feed, failing to complete the prescribed regimen, and using someone else's leftover prescription. So here's your check your understanding question. If you got any questions, please make sure you ask me. Antibiotic safety. So therapeutic index is a risk versus benefit. The reactions of antibiotics with other drugs, damage to organs, risks to fetuses. So there's a lot of risks with antibiotics, and it's not one of those things that's clear cut. Some people happen to be allergic to antibiotics and can have huge reactions to them. So next we'll talk about the combinations of drugs. So synergism is when the effect of two drugs together is greater than the effect of either one alone. And antagonism is the effect of two drugs is less than either one alone. And so here is a example of synergistic inhibition. And you can see how there's this extra space here. When these two discs come together and get close to each other, they produce this extra space here that's not always here if we just had this one and this one in the plate. And so you can see how that could be very useful. If you can combine two antibiotics and make a stronger antibiotic to treat this patient, you might have to give them less of that antibiotic. So here's your check your understanding question. And lastly, the future of chemotherapeutic agents. So the future ones are going to target virulence factors. They're going to sequester iron, which feeds the pathogens, antimicrobial peptides produced by various organisms, phage therapy, bacteriocins, which are antimicrobial peptides produced by bacteria. And so a couple of the really cool ones I'll point out here, phage therapy. What's interesting about phages is a bacteria has generally a small genome, and the genome can only contain so much. And so when antibiotic resistance, I'll call it AR, goes up, resistance to phages, which is a virus, phage resistance goes down. And so the opposite happens. When antibiotic resistance goes down, phage resistance goes up. So you can have one or the other, but you can't have both. And so this is why they're saying, well, we need to start using phages because the bacteria aren't used to it. And so it's a very interesting area of research, and they've actually started some clinical trials on this. So it's a really, really cool, groundbreaking kind of research. It's been around for a while, but a lot of people haven't been able to really get into it because it's been such a kind of a hard thing to do.